On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speakers, Dr. Thomas Miner and Dr. Angela Paddack. Dr. Thomas Miner is board certified in internal medicine, pulmonary medicine, critical care medicine, and sleep medicine. He graduated from Johns Hopkins School of Medicine and completed his internal medicine, pulmonary, and critical care training at the Mayo Clinic in Rochester, Minnesota. Devoting much of his time to treating sleep disorders, Dr. Miner sees patients at Boulder Valley Pulmonology. Dr. Angela Paddack is board certified in otolaryngology. She earned her medical degree at Texas Tech University Health Sciences Center and completed her residency in otolaryngology and head and neck surgery at the University of Arkansas for Medical Sciences. Dr. Paddack provides the full range of adult and pediatric ear, nose, and throat conditions. She enjoys helping patients with their breathing and sleep issues and has been working with Inspire, a minimally invasive surgical alternative to CPAP, since 2019. Dr. Paddack sees patients at Boulder Medical Center. Welcome to tonight's speakers.
Thank you very much for that introduction. And I'm Thomas Miner, and I'm going to talk a little bit about sleep apnea. We're going to start by talking about what sleep apnea is and the diagnosis of sleep apnea. We'll talk about the types of sleep apnea, and then we'll talk about some typical treatments. And then after that, Dr. Paddack is going to talk about surgical treatments. I'll be talking about most of the other treatments available. So sleep apnea means that you stop breathing at night. That literally is what apnea means, is that you have periods where you stop breathing at night. And that results in a variety of signs and symptoms. One of the most common one is snoring. Not everybody who snores has sleep apnea. Most people who have sleep apnea do have some snoring. They may also, bed partners or sleeping partners may notice that they stop breathing at night. They may actually have witnessed apneas. Sometimes patients themselves will wake up gasping or struggling to breathe. They can also have dry mouth. They may also not feel refreshed by their sleep, so they can sleep a full night and not feel refreshed by their sleep. So those are a couple of common symptoms. We'll do a sleep history when we first see a patient with sleep apnea, and we'll ask about those symptoms, their typical bedtimes, any other behaviors that they may have at night that are bothering them with their sleep. Also their sleep, whether they have health conditions that could be associated with sleep apnea or be contributing to sleep apnea. And once we've done that history, then we'll have to decide, are we going to do a test? Is there enough suspicion that a patient has sleep apnea that we should do a test? And there's two main tests that we can do to diagnose sleep apnea. They're the same principle. You're watching somebody sleep overnight to determine if they have sleep apnea, but one is done at home and one is done in a lab. So the one at home involves getting a device that you usually pick up from your doctor's office or will be mailed to you. And there's a variety of different devices. Some of them just fit on your finger and wrist. Some of them fit on your head. Some of them fit on your chest and have cannulas that go up to your nose. You put those on, you turn them on, you wear it overnight, and then you turn it in, and that records overnight, and then that data can be interpreted to help determine if you have sleep apnea. The gold standard for diagnosing sleep apnea that's a little bit more accurate, more kind of thorough test is called a polysomnogram. That's also known as a sleep study, and that's where you come into a sleep lab and you're hooked up to a whole bunch of monitors, and you have wires around your face, your nose. You have wires to determine whether you're awake or asleep, to do basically an EEG to determine whether you're awake or asleep, and measures around your chest, bands around your chest to measure your breathing. There's wires around your feet to measure movements, and you're also under video recording, so we can help determine whether or not you have sleep apnea by watching your breathing, watching whether you're asleep or not. The benefits of doing the home sleep test are that it's less expensive, it's more convenient for most patients to be able to do a sleep study at home, and it's and it's similar to another study that sometimes people get confused about called an overnight oximetry. That's a test also done with a little probe on your finger, and there's usually attached to a watch. That one just records your oxygen level and your pulse, and it can be used to screen for sleep apnea, but it's not a diagnostic test for sleep apnea. These other tests, the home sleep test and the polysomnogram, are actually the tests that you need to formally diagnose it to get insurance to pay for the study or for any treatment and to be considered an official diagnosis. So the home sleep test is more convenient and easier to do and quite a bit less expensive. But there are some advantages to doing the polysomnogram, one of which is that we can both diagnose you with sleep apnea and also sort out some other sleep conditions. We can see whether you're having any other things like periodic limb movements. We can determine if you're having nightmares, if you're having REM behavior disorder. There's a whole variety of other disorders that we can determine. It also can tell quite accurately whether you're asleep or not. A home sleep test can't do that. So if you take a home sleep test but you're awake for quite a bit of it, it could give you some inaccurate results, whereas when you have an in-lab study, it actually is able to determine whether you're asleep or not and gives more accurate results. When we do an in-lab study, we can also determine, we can also start you on treatment. Can I get the water? Thank you. We can also start you on treatment called CPAP is the main treatment that we'll use to start when people are in a lab. So we can actually get you started on the CPAP or other treatment and determine whether or not it's going to work well. We can find the right pressures. We can adjust the pressures to get the best settings for you, and even determine whether CPAP's right or whether we should use another type of device, like another device called ASV that I'll also talk about. So although it's a more involved study, it does give us some more information than a home sleep study. It also, and sometimes we'll have to do a in-home sleep study and then do an in-lab study in order to kind of accurately figure out what the appropriate treatment and appropriate pressures are. So once we've determined that we think you have sleep apnea, we also need to know which type of sleep apnea you have. The in-lab studies are probably a little bit better at separating these two out depending on the type of home device that you have, but there's basically two types of sleep apnea that we're dealing with. One is called obstructive sleep apnea. As you can see from this diagram here, obstructive sleep apnea is when the tongue and or the soft palate relax during sleep and block airflow. You can kind of see the blue ribbons there going, those are demonstrating air going back through your mouth or through your nose down into your airway and into your lungs. Well, when the tongue or the soft palate relax enough, they can actually block that airway so that you're not getting air. So that's why it's called obstructive, is because the airway is obstructive. This is the most common kind of sleep apnea. It affects over 20 million Americans, 20 to 30 million Americans, depending on the severity that you cut off that you have. So obstructive sleep apnea is the most common kind across the board. It's probably 97% of sleep apnea overall, or certainly in the upper 90s. But at this altitude, we actually see a higher percentage of than that of central sleep apnea. Central sleep apnea is only a few percent in general. But up at this altitude, we see up to closer to 20% of patients will have a component of central sleep apnea. Central sleep apnea is when the brain is failing to send a signal to the muscles, to your diaphragm and your muscles to breathe. So what that means is that you're the way I kind of describe it to patients is that it's kind of like they're over-breathing and under-breathing. They kind of get ahead of themselves, they kind of hyperventilate, and then the brain tells them, stop breathing, we've got enough oxygen, we've got the carbon dioxide out, stop breathing, you stop breathing for excuse me, for a short period of time and then start breathing again. So that's less common, but at this altitude, it's a much more common, it's a more common scenario when we deal with that quite a bit here at this altitude. So why treat sleep apnea? There's a variety of reasons. I usually break it down into about three main reasons we treat sleep apnea. Number one is up at the top middle, is that your sleep apnea, and this is often a reason patients come to us, is that there's a bed partner is kind of is noticing, they're concerned, their sleep is disturbed by the person who has sleep apnea because they're snoring, they're stopping breathing, and that makes the bed partner concerned or just plain bothers their sleep. They may even have to leave the bedroom in order to get sleep themselves. So that's one reason. Another reason is that when you have sleep apnea, it can disturb the quality of your sleep. So you may sleep for a full 8 hours and feel like you should be refreshed, but you're not. And that's probably because the sleep apnea is disturbing the quality of your sleep. When you try to get into when you're trying to sleep, your brain's ready to go to sleep, and then it stops breathing and has to kind of wake up. It gets stimulated. You're just getting you can't get into deeper restorative sleep, so you have later stage sleep. It's often fragmented, and you're just not getting good quality sleep. So the patient themselves may feel fatigued, tired, sleepy during the day. They're not able to concentrate. They're nodding off during the day. It increases your risk of driving-related car accidents. Up to about 20% of car accidents nationally are felt to be due to under or untreated sleep apnea. So it's both a personal and a community risk as well. The last reason we treat is kind of some of the more silent reasons, and it's something I often spend a lot of time talking with patients about. That is, we know that untreated sleep apnea, in addition to the symptoms, increases your risk of a whole host of medical problems. We know that untreated sleep apnea is associated with an increased risk of high blood pressure. It's associated with an increased risk of atrial fibrillation, heart attacks, strokes, pulmonary hypertension, heart failure, diabetes, erectile dysfunction, dementia. All these things are at higher risk in patients who have untreated sleep apnea. And for many of those, especially the cardiovascular risks, we know that if we treat the sleep apnea, we reduce those risks. That's especially true with obstructive sleep apnea. It may not be quite as true with central sleep apnea. That's not as well studied, but a lot of times that's one of the important things I want to impress on patients, that even if they're not that symptomatic from it, by treating sleep apnea, we're helping them to get better sleep, and that can improve their health. So then we have to get to talking with patients about, once we've diagnosed them, about sleep apnea treatment options. And the number one treatment option first, which is usually the first option for most patients, is CPAP. So CPAP stands for continuous positive airway pressure. And what it is it's a mask that fits over your nose or mouth. It's attached to a machine. You can see there's a machine in this left picture here. There's a machine that's sitting on their bedstand, and it's attached to a tube that goes to the mask that's on the patient's face. And those masks have gotten smaller and more comfortable over the years that I've been treating patients, so that usually patients have got a fairly wide option of masks to try, but you can't get away from the basics of it, which is that in order to treat with CPAP, you have to have a relatively tight-fitting mask over the nose or the nose and mouth. By applying pressure, you're stenting the airway open. The machine isn't quite like a ventilator. It's not actually breathing for you. What it's doing is it's applying pressure, and by applying a pressure here, it just pushes the tissues open enough to help keep you so that you can breathe yourself. It's not actually breathing for you. The CPAP is generally very effective, or CPAP, or it's the other versions of CPAP. There's one called BiPAP that is a similar therapy. Those therapies are very effective generally at treating sleep apnea. The biggest question is whether people can tolerate it. Some studies show that only about 50% of patients tolerate CPAP. I find that it's usually quite a bit higher if you really work closely with the patient. Those studies often didn't have good follow-up, or the patients weren't really working closely with their provider to work through problems, because a lot of patients will have initial resistance to using it. They may just be given a CPAP and told to use it and not have good follow-up, not have any resources for if they have problems with it, like the pressure's too high or too low, or the air is too dry, or the mask doesn't fit right. They may not have resources to kind of work through that. But I find that if I work through those with patients and actually ask them, you didn't like CPAP, what was the problem? What can I help you with? We can probably get closer to 80 or 85% success rate with CPAP. There's also, if CPAP itself doesn't work, there are other treatment options that are related to that as well. One's called ASV. You'll probably hear a fair amount about that if you're in the sleep apnea world at this altitude. That's a form of BiPAP, and what that means is that it has a different pressure when you breathe in than when you breathe out. And the ASV it will synchronize with your breathing so that when you have those episodes, like I had mentioned, when you have central sleep apnea where you're kind of under breathing, it'll pump up the pressure to try to make those smaller breaths bigger. And then when you start breathing heavier on your own, you start to try to do those catch-up breaths, it'll turn down. And by doing that, it can help stabilize your breathing pattern. So usually we may start with CPAP, which works for obstructive sleep apnea. The ASV can work for both central and obstructive sleep apnea. And between the two of those, we usually can get, I'd say, 80 to 90% of patients effectively treated with one of those two. Another treatment option is oral appliances. Now, these are usually fit by a dentist. And what they are is they're a custom-made mouthpiece that fits over the upper teeth and the lower teeth. And then there's a retainer or a band or a post or something that pushes the lower jaw forward relative to the upper jaw, or rather relative to the upper teeth. This can be effective for patients, especially for patients who have mild or moderate sleep apnea. We break sleep apnea down to the numbers that we used for sleep apnea, the way we diagnose the severity is by how often you're having those breathing events when you stop. We say normal is less than 5, mild is 5 to 15, and moderate sleep apnea is 15 to 30 events per hour. And these oral appliances are best for patients that are more in the 5 to 15 or maybe up to 30 events per hour. They can work for patients that are more severe, but they're less likely than CPAP to really bring things down to the normal range. So I will often recommend CPAP or oral appliances for patients that have milder sleep apnea, especially if they have positional sleep apnea where they're worse on their back, but they're not so bad on their side. Those are patients that are good candidates for this. I think of these devices as coming in kind of 3 levels of kind of quality and kind of expense as well. You can get kind of just boil and bite ones where you just yourself kind of put it in hot water and bite down on it, and they give you some instructions to kind of put your jaw forward and bite down on them. Those cost maybe $100 or so. The next level is to have your, kind of a local dentist who may or may not have a lot of experience at doing them. They can do a custom fabricated one. And then there are ones that are made by dentists. There are some dentists that exclusively specialize in this, and this is their kind of full-time practice. And I think they often do the best job in terms of giving you dealing with TMJ problems that can come up, temporomandibular joint pain and things like that can come up with these. Those may or not be covered by insurance depending on whether your dentist takes insurance. Those can run hundreds to even thousands of dollars to have those made. And again, those may or may not be covered by insurance. The main limitations are just whether you have the dentition for them, whether you have TMJ problems for them. Some people just can't tolerate them because they bother their mouth or they have drooling or whatever. But a good dentist who has experience in these can often work through a lot of those problems. Another form of therapy that I'll often address with patients is positional therapy. So that means therapy in which we're trying to keep you from sleeping on your back. About 50% of patients will have significantly worse sleep apnea when they're on their back than when they're on their side. And for some patients, that's a big enough difference that they're either normal or they just have very mild sleep apnea when they're on their side, but when they're on their back, they're snoring. And a lot of patients will report that or their bed partner will report that they're on their back, they're snoring. When they're on their sides, they're fine. We can also see that in the sleep studies that if you only have much milder sleep apnea or normal frequency of respiratory events on your side compared to your back, we just try to keep people on their back. And some patients think they can do it. They'll do it on their own. Sometimes we'll find patients will say, yeah, I never sleep on my back. And then we'll do a sleep study and find out that they do. It's kind of a surprise to them because they don't know what position they're sleeping in. But positional therapy is designed to keep the patient in a position where they're not sleeping on their back. There's a couple examples here. There's the simplest one is to just get a t-shirt and put a pocket in the back and put some tennis balls or wiffle balls or something like that in the pocket in the back so that when they roll over onto their back, they feel uncomfortable and they kind of pop off and hopefully go right back to sleep. You can see this picture here, the guy with the black band on his eye. He's got a little more robust one that's a commercially available device where it's a kind of a band, like a cummerbund almost that goes around their chest, and sometimes they'll have shoulder straps as well to keep it in place. And it's got some big bolsters in the back that really keeps you from sleeping on your back. That's, again, helpful for patients that have got the strongly positional sleep apnea and we just want to make them better, or that are, their sleep study shows that the severity of their sleep apnea is such that just avoiding sleeping on their back would be good enough. The limitations are just whether patients are willing to reliably wear the device and can avoid sleeping on their back without being uncomfortable. Some patients just can't reliably sleep on their back because they've got issues with hip pain, back pain, neck pain, things like that. One of the things I have to work through with patients often when they're trying this is that patients, when they sleep on their back, you can have a firmer mattress and a shallower pillow. When you're sleeping on your side, your hips and shoulders are sinking into the bed more, and if over time that can get to, if you use that night after night and you're not used to it, it can be more uncomfortable. So usually patients who are sleeping on their sides need a softer bed or like a pillow top, something that they can sink into better. Sometimes extra pillows like between their legs or under their side, just to help kind of keep their spine straight and keep the pressure off of their hips and shoulders. Most patients, if I can work on that, unless they have real problems with hip or shoulder pain, we can get them to avoid sleeping on their back. The last thing I wanted to talk about is weight loss, and this is, I think, one of the most exciting kind of developments in sleep apnea in the last decade or two since I've been taking care of patients with sleep apnea. You know that sleep apnea is worse in patients that are obese. Not all the patients that are obese have sleep apnea, and there are many patients who are not overweight who have sleep apnea. A lot of times sleep apnea is just related to kind of the jaw shape and the airway shape and morphology, but we know that sleep apnea tends to be much more common in patients that are obese, so it makes sense that if patients can lose weight, then their sleep apnea might get better. And studies over the years from the 80s, 90s had shown that sleep apnea does get better if people can lose weight. The problem is, with all those studies, that it was hard for people to consistently lose weight. There really weren't many good studies with that because, say, in the absence of bariatric surgery, the success rates for successfully losing a substantial amount of weight and keeping it off are disappointingly low. There were studies with bariatric surgery where people have like stomach stapling procedures and bypass procedures, and those showed some good results, but it was relatively small numbers in the studies. And so we didn't have really good data that kind of confirmed what we thought, which was that weight loss could help patients improve their sleep apnea. Well, this past summer, a study came out using tirzepatide, which is also known as Mounjaro and Zepbound. That's two of those weight loss drugs that have been kind of in the news pretty much continuously for the last few years, and using those for sleep apnea. So they took a large number of sleep apnea patients. They had about almost 500 sleep apnea patients who had moderate to severe sleep apnea. You can see they had an average of about 50 events per hour. So the average was in the severe range. They could have as few as 15 events per hour, but these were generally patients with pretty severe sleep apnea. Their average BMI was 39, which is morbidly obese. Their average weight was 250 pounds, and they divided them up into either being on this weight loss drug or not. And then they looked at them in a year later, and they'd had pretty significant weight loss, 17% reduction in weight. So that would be like a 40-pound or so weight loss for these patients on average. But remarkably, they had a reduction in their AHI of about 58%. And about half of all patients were reduced to either having a normal AHI, meaning less than 5, or they just had a mildly elevated RDI, but their symptoms were much better. They were not sleepy. So they really didn't have symptoms of sleep apnea. And those were both of those outcomes were considered success, either to be normal or to be just mildly elevated but not have symptoms. And about 50% of patients were able to achieve that. In addition, their blood pressures got better by about 4 to 10 points or so. Their inflammatory markers got better, and their symptoms were improved. So this is really pretty exciting because this validates that weight loss can potentially help, and this offers, I think, a lot of hope for patients who are overweight and have sleep apnea. Maybe they haven't tolerated other therapies, or even if they have, there's all the benefits of potentially losing a significant amount of weight in terms of other health parameters as well. And so this has been very exciting. they're hoping for FDA approval later this year and maybe being able to market this and even and sell this specifically for have this as an indication by early 2025. So we'll see how this pans out. We're hoping to get more access to this. This will be one more reason that patients will be able to justify getting these medications. It can be very helpful. The one caveat I'd say with this is that they just looked at these patients at 1 year. We don't know what happens to these patients 5 years later. We know that many patients have, when they look at studies of patients on these medications, compliant or long-term compliance, meaning staying on these medicines, is better than 50%, but not much better than that. And that may have to do with tolerating the medicines, but also just being able to pay the cost of these medicines. They're prohibitively expensive for many patients now, especially if they're not covered by insurance, and sometimes even if they are. But also what happens 5 years from now, we do know from some of the data, smaller studies on patients who had bariatric surgery, that they did well after the bariatric surgery. They lost all their weight, but then if you looked at them 5 or more years later, they would gain some weight back, but their apnea-hypopnea indexes would actually come back up. So we don't know what's going to happen to patients 5 years from now. Those studies have not been done yet. But nonetheless, I think this is still very exciting. It's something I'm talking to my patients a lot more about. This is an option that can help you. And again, even if you're on CPAP and getting treatment, and if we have effective treatment, this may be a good option for patients to consider. Have this be an indication, maybe get their insurance to pay for it, and help them lose a significant amount of weight and get some of the other benefits from that as well. So that's my part of it. I'm going to hand it over to Angela Paddack, who's going to talk about surgical options.
Hello, hey, I'm Angela Paddack. I'm an ENT with Boulder Medical Center. I've been in practice here since 2014, and like they said before, we've been doing Inspire since 2019. And I think a lot of y'all want to talk about Inspire, but also that's kind of not the only option that you can have for surgical treatment for sleep apnea, and so I wanted to talk a little bit about that as well. But basically, sleep apnea, which Dr. Miner kind of mentioned, is sometimes multifactorial and it's multi-level. So, you could have nasal obstruction that's increasing the resistance. You could have palate that collapses. You could have huge tonsils, and you can have a base of tongue that falls back. And so all of those things are things that could potentially be fixed surgically, some easier than others, but, that could include doing a septoplasty and a turbinate reduction, which is fairly simple, an outpatient. It could include doing a tonsillectomy, or shortening the palate, which we don't do quite as much anymore, but in some patients it could be beneficial. And then also there is the Inspire, which is one of the other things that obviously we're going to talk about tonight. So the one other thing about the sleep stuff, as far as surgical treatment, I basically tell people that, it kind of depends on what level of sleep apnea you have to determine which level of treatment you're going to want. If someone has really severe sleep apnea and they have nasal obstruction, we can fix your nose, but that's often not going to be enough to truly fix the sleep apnea. It may bring you down, or sometimes it can help you tolerate the CPAP in the sense that you can breathe better through your nose, so you're able to keep the CPAP mask on better. But again, if you have really severe sleep apnea, doing only that is not the best option, and so frequently we do that in combination with the Inspire. So this is a picture of what the Inspire is. And so basically what that is, it's a hypoglossal nerve stimulator. And it's kind of a cool thing. They're, I think on the 3rd generation now, but basically it has a breathing sensor in between the rib space, and it sits in between some of the muscles in the ribs. And basically what happens is every time you breathe in, that sends a signal up to a little cuff that's around the nerve that works your tongue. And so, like Dr. Miner mentioned, a lot of times, especially if you're sleeping on your back, your tongue will fall back and collapse, and that basically causes obstruction. And so what the Inspire does is it sends a signal up, and when you breathe in, it pushes the tongue forward. And so what that does is it very specifically opens up the airway at the level of the tongue and the palate. And kind of like I talk to patients as well, CPAP works somewhat non-specifically in the sense that it just kind of shunts a bunch of air in there and it opens everywhere, which is great. But the Inspire works a lot more specifically at mainly the base of tongue and the palate. So the Inspire indications are moderate to severe obstructive sleep apnea. The FDA actually just increased the AHI, which is your number of kind of decreasing in breathing or apneas per hour to 100. It used to be 65. So the caveat to that is that it's FDA approved, but not all insurances are following that currently. You also have to try CPAP and just, give it a good go. Some patients, we fix their nose and then they tolerate the CPAP and they do really well. Some patients, they have, claustrophobia or PTSD, or they just really don't like things on their face, or they just, the CPAP sometimes is more trouble than not wearing the CPAP and they don't wear it consistently. So that's reasons, but you have to try the CPAP. You also have to have a BMI criteria. So it previously was 32 to 35, depending on your insurance. Again, FDA just cleared it for a BMI up to 40. And again, all insurances aren't necessarily following that currently, although we expect them to pretty soon. The last thing you have to do is pass an airway exam, which is actually called the drug-induced sleep endoscopy, or a DISE. And basically what that does is it's kind of a guarantee that the Inspire is going to help. So in some patients, if they're collapsing circumferentially or laterally, which means the sides of their throat are falling in, the Inspire is not going to help as much because the Inspire pulls the tongue and palate forward. So the DISE basically looks at the upper airway and makes sure that they're collapsing in a forward-backward movement mostly, because we want to make sure that you're going to have the best benefit. So it's most of the time an outpatient procedure. Sometimes we keep patients overnight if they have other comorbidities or whatnot. The picture on the left is a picture of the battery, and that's what sits right here over the breathing sensor. So there's two incisions, one here in the upper chest and then one here in the upper neck. And basically, this guy on the right is holding the sleep remote. That's the thing that you have to keep track of and not lose. But basically, the Inspire is not on constantly. You turn it on right before you go to bed. And basically you get a little stimulation and a tone which tells you that this Inspire is on. And then the Inspire is pretty cool in the sense that it has a lot of ways that you can tweak it to make sure that you tolerate it. So if it takes you 20 minutes to fall asleep, you can set it to actually activate at 30 minutes. So the whole goal is that you're asleep prior to it turning on and you noticing it. So again, it's two incisions. They're both 5 centimeters, so about this length here. And then here, they typically heal really well. Recovery is pretty easy in the sense that the incisions heal pretty fast. Patients do get narcotic pain meds, although not all take them. And you can do Tylenol if needed. And then basically, it says return to non-strenuous activity within a few days. I usually tell people 2 weeks. And it's not like you can't go out and walk or anything, but I don't want you to do any heavy lifting or straining for 2 weeks. The battery, which is the generator, that lasts for about a year. We haven't been doing this long enough for me to have somebody that needs a battery replacement, but that's a much easier procedure than doing the entire Inspire. You just have to replace the one piece. And then again, Inspire is now approved for full body MRI. So in the past, people were concerned about getting like a CT scan of their chest, or an MRI of their chest, but now you don't have to worry about that. You can get an MRI of any body part. So this is a video of this guy falling asleep. He's got the remote. You put it over the battery on your chest. It kind of dings. And so basically, this is an old video because it has the breathing sensor lower down than the generator. But the generator is the battery pack, and the breathing sensor, again, it's sending a signal to the tongue, and it's pushing the tongue forward. So you can see as that's happening, the area in the green circle, you've got more space back there. So that's how it works. So as far as turning on the Inspire, this is something that I think is important for people to know. It's not just like you get the surgery and then it's done. You get the surgery, you allow it to heal for about a month, and then you follow up with the sleep doctor, so Dr. Miner or one of his partners. And basically, they're going to be the ones that actually turn on the Inspire. And what we do is during surgery, we actually test it and we prove that it's doing what we want it to do, which means that it's pushing the tongue forward. We want to make sure that we're not getting any branches in the nerve that could pull the tongue backwards, because that's obviously counter to what we're trying to do. We make sure that the breathing sensor has a good waveform and you don't have any cardiac interference. And so once we have that, we determine your kind of like, default setting. And for everyone, it's going to be different. So when the sleep doctor turns on your Inspire, they're going to turn it on to that lowest level that we tried you at, that you got some movement of the tongue. And so once you get that, that's your level 1. And then the sleep doctor is going to, print you out this list that basically gives you 10 levels. So you start at level 1, you wear that for a couple nights, assuming you do okay and you tolerate it, you don't have any issues as far as pain or discomfort or waking up. You'd go to level 2 after 5 to 7 days. You do okay, then you go to level 3. Some people do a little bit quicker than that, but the recommendation is 5 to 7 days before you go up a level. And all of that is to basically allow your body to kind of adjust to what this is doing. If you just go automatically to level 10, I think you're going to wake up with the stimulation. You're going to probably have a little bit of a sore tongue and a jaw. And so the goal is that we do it somewhat slowly so that once you get to your peak level, you're at a high enough level that it's going to give you benefit. So let's see, they talk to you about how to do the sleep remote, and they also do those specific things like tweaking it to when you want it to turn on after you fall asleep. And this is the sleep doctor. He's got his little Inspire programmer. He's looking at the settings. They basically look at the mouth, and it doesn't actually show it, but basically they look at the mouth and they want to see the tongue move. So it's not like the tongue is like jutting out of your mouth or anything. Granted, during surgery it is because we're testing it at pretty high levels, but when you initially turn it on, it's really just kind of a twitch. So people ask a lot of times, are they going to feel it? I mean, you do feel it initially when you turn it on. Again, there's that initial twitch to say that it's on. But again, the goal is that you're gonna be asleep prior to turning on. And if you get to a level that feels uncomfortable or that wakes you up, that means that you're kind of at your peak level and you go back down. And so not everyone gets to level 10. Some people may get to 5, some people may get to 7. So, there's been a bunch of studies on Inspire. Basically, the main thing is that you get about an 80% reduction in your AHI. So, in this data point series, which I think was the STAR trial, showed that before Inspire, the average AHI was about 30. After Inspire, they got it down to about 6.2, an 80% reduction. And then a lot of people say, is this going to help my snoring? So I never tell people that we're doing this for snoring or that this is going to, cure your snoring. Now, granted, if it improves your obstruction and improves your airway, it should improve your snoring too. And that's what the study showed. There was around an 80 to 90% improvement in snoring as well, reported by the bed partner. But again, that's not the goal of the surgery, although I know that's a really big part of why people want to treat this. And it does help, but we don't do this, really only to treat the snoring. As far as patient satisfaction, the vast majority of patients like it. They wear it. Patient adherence at final visit, therapy per night was around 6 hours, which is pretty good. That's another thing you can tweak on the Inspire when you turn it on. You can determine if you want to set it for 6 hours. It automatically turns off at 8 hours, but if someone only sleeps 6, you can set it for 6. It also has a pause mode, so basically if you wake up in the middle of the night and you have to go to the bathroom or something, you can pause it. It'll pause for 20 minutes. The goal is that you fall back asleep and then it turns on. And again, I think there's more and more data that's showing up. I think the article that Dr. Miner was talking about with weight loss is huge in the sense that we know that weight loss can improve sleep apnea now. I think it's also an interesting thing where, in the past and even now, I guess, if someone's BMI is too high to qualify for the Inspire, sometimes those weight loss drugs can potentially be helpful to get you to a lower BMI prior to surgery, and then you'll be a candidate. So I think that's kind of another option as well. And I didn't mention that, but most insurances cover it. The only insurance carrier that does not cover Inspire at this point is Medicaid. Yeah, that's it. So thanks so much.
Bring Dr. Miner back up here too. Appreciate that presentation from both of you guys. And we want to remind our audience that now is the time that we'll be going through our Q&A. And if you have any questions, please submit them in the bottom chat, and we'll get to just as many as we can tonight. And I'll be going through these in no particular order. And doctors, you just field them how you would like to. So, this person has been told their apnea is too much for Inspire to handle. What would you recommend?
I mean, that's a hard question because we don't really know what your sleep study shows. I mean, that could be, again, in the prior FDA criteria, your AHI couldn't be higher than 65. Now the FDA has approved it up to 100. I think one thing to note is that the higher your AHI, potentially the higher it is going to be after surgery as well. So, like Dr. Miner and I were talking about this previously, but, CPAP can get people down to normal very, very often. It just depends on if they can tolerate it or not. The Inspire, it's kind of similar in the sense that, if we put your stimulation up super, super high, we could get you down really low, but that may not be tolerable. And so I tell people, if you think about an 80% reduction in your AHI, the higher you start, the higher you're going to finish. But I also think that if you're not going to do anything to manage your sleep apnea anyway, in the sense of CPAP, and you can't tolerate it, then getting it lower is better than nothing.
Yeah, I just emphasize, why CPAP for somebody who's too severe for Inspire, regardless of that was somebody who was 70 before, or their doctors just told them, no, we won't do it, or maybe you're 120. CPAP or BiPAP, one of those forms of therapy, can be effective. I mean, I've had patients that have an AHI of 150, and I may not be able to make them normal, but I can usually get them 90%, almost all the way there. So it would be, let's revisit CPAP. Can we work through that with you? Just work with, claustrophobia, whatever your issues were with tolerating CPAP. And then also, I think weight loss is now another big one. If your BMI is over 30, then we should really kind of working on that can make you significantly better. Besides those two, no other therapy is really going to be very effective for somebody who's, if they've been told realistically that they're that severe, too severe for Inspire. I'm presuming that means it's somebody who's in the 60s or more in terms of their AHI.
Okay. What is your opinion on inline CPAP, APAP filters? This person has seen information on them and seems like a good addition to the machine/hose.
Now, if there's talking about viral filters, the machines have got filters in line already. You can add extra filters if you're concerned about viral, kind of getting down to the micron, the less than a micron kind of thing for viruses. If that's a concern of yours, they're certainly available and can work. But the machines themselves have got filters that will filter out most kind of particulates. You can get an extra inline filter that can get down to filtering out viruses and other even allergens, pollens, things like that. If you find that that's helpful, it means that most everything, all the air that you breathe will be essentially purified, kind of like having a HEPA filter in your CPAP.
Okay. Please remind me, can I have access to Inspire if my diagnosis is just mild, not moderate?
No. So that's where we might want some of those more, other options. So yeah, you're not a candidate for Inspire if you have mild sleep apnea, but that could be potentially where the mandibular advancement device could be helpful, potentially opening some nasal patency with different procedures or a tonsillectomy or something like that.
How does one go about getting a CPAP machine that is covered by Medicare, specifically a Respironics Dream Station?
So there's a couple criteria you have to do in order to get CPAP paid for. They're relatively straightforward, but you got to jump through all the hoops. First is you have to see a Medicare accepting provider in the state that in Colorado. So you have to see somebody, basically a doctor, NP or PA, who can do it, who does a note, and they say, I think you have sleep apnea. So that's got to be in the note, is that I think maybe you have sleep apnea. Then you have to have a sleep study. So one of the studies that we talked about, either an in-lab or an in-home sleep study, if that shows an AHI over 15, you will qualify for CPAP. If you're between 5 and 15, you have to have an associated diagnosis, like you have to be sleepy, you have to have had cardiovascular disease, something else like that. So if you meet those criteria, either an AHI over 15 on a study or 5 to 15, and you've got an associated diagnosis or comorbidity, you will qualify for payment by Medicare. They'll pay it. There's one more hoop you have to jump through, and that is after you're put on it, you have to demonstrate that you're using it. So Medicare, the way it works is they will rent it for about 3 months. They'll pay the company that provides the CPAP to you. They will pay for it on a monthly basis for 3 months. And then you have to have another note from a provider saying they're using the CPAP. You have to prove that you're using it. The machines will have a little download, have a recorder that records how much you're using it. You have to demonstrate that you're using it to 70% of nights for at least 4 hours a night. And you'll hear that from the people that give you the CPAP machine. Once you jump over that hoop, then your CPAP will be fully paid for by Medicare.
Do you
It's
accept
pretty much yours.
Medicare?
Yes. Oh, yeah. Yep.
Okay.
So once you don't jump through those hoops, Medicare will pay for the whole thing. And your supplies after that, your masks, replacements, and things like that.
Okay. Can you discuss central apnea, please? This person consistently uses a full mask CPAP machine. They have about 35 plus episodes per hour.
Yeah, so that's common. As I mentioned, the central sleep apnea is fairly common. It's where you stop breathing and start breathing because your brain is telling you to overbreathe and underbreathe. Not common at sea level, only a few percent. Up here, it's more common. If you're living up even in the mountains at higher altitude, it's even more common. So we see an awful lot of that. CPAP works maybe half the time. The treatments for that are CPAP maybe works half the time. There's this other device called ASV, which is a fancy form of BiPAP, which, unlike CPAP, it varies the pressure when you breathe in and breathe out. That in order to get that, you have to go back to the lab one more time, at least one more time, and demonstrate that you have central sleep apnea on CPAP. It has to be at least 50% central sleep apnea. And if you show that, they'll put you on ASV in the lab, and if that helps, then you can get ASV paid for. And that works, I'd say, 90% of the time. So if this is a patient that's saying that maybe I'm not sure if it was on their baseline sleep study or on the download from their CPAP machine. When we put somebody on CPAP, I get a lot of data. The CPAP machine basically scores itself. It says how much you're using it, but it also tells whether you're having events and what type of events. If you're having a lot of events on that, and I can't fix them by adjusting the CPAP, I will have them go back to the lab, get an ASV titration, and 90% of the time, not 100%, but 90% of the time, we can get that treated with ASV, and so then we'll get you an ASV device. They look exactly like a CPAP machine. They cost about 4 times as much, but they do the job very well. They are covered by insurance. The other option is oxygen actually works fairly often. The one caveat with that is that insurance generally won't pay for it. For some reason, all these rules about what works and what doesn't work are made by people who live in Washington at sea level, and they don't understand that there's some people that the treatment for their central sleep apnea is to kind of mimic sea level by putting you on oxygen and giving you the extra oxygen that we're lacking here. That'll treat a fair amount of the central sleep apnea. Sometimes getting that paid for is a little tricky, but it's less expensive than ASV too. So I have patients that sometimes just buy an oxygen concentrator at home. They generally cost $500 to $1,000, and sometimes that's just the treatment that you need, and we'll figure out a way to either get your insurance to pay for it, or patients will figure out a way to get one.
Okay. So you've kind of alluded to this. Is there anything more that you need to expand on as far as the topic of does altitude affect sleep apnea?
Yeah, significantly, mostly in the central sleep apnea. I have a couple patients that don't exactly understand why. They go down to Arizona, their obstructive sleep apnea seems to get better and it's worse up here. I have to presume that there is some overlap, that although the physiology of obstructive and central sleep apnea are very clearly different, some patients, they kind of overlap, and I think their brain starts playing games with them when their obstructive kicks in. So we definitely see the higher you live or sleeping, the more likely you are to have certainly central sleep apnea and maybe even obstructive sleep apnea. If you're sleeping up at 10,000 or so feet, the majority of people have some degree of central sleep apnea at that altitude.
One thing I was going to mention about Inspire that wasn't on the slide is that if your central apnea is too high, you don't qualify for Inspire either. So you can have up to 25% of central apnea on your sleep study. But if it's higher than that, you don't qualify for that reason. It's probably not going to fix it.
It doesn't help.
Okay. If the patient lives at high elevation greater than 7,500 feet, does a polysomnograph study give accurate results?
Yes, absolutely. So we have 2 options for patients that live up at higher altitude. One is to do the home sleep study. So that's one of the advantages. Although I often would like to have all the data from an in-lab study, it's not as helpful to have a patient who lives up in Ward or Netherland come down here and have a sleep study, because it doesn't really tell me what their sleep is like up there. So those are patients I'm more likely to do an in-home study on. Although we also can do studies with an altitude tent. So there's one in Broomfield where you can come down, live up in the mountains, but then we can simulate that higher altitude, and I'll routinely do that. It'd be uncommon for me to have a patient who lives up at altitude, for me to study them down at this altitude in a regular sleep lab without trying to simulate their home altitude, because they can change their sleep apnea, but it also they may have low oxygen levels up there that aren't as apparent here. So by having a good study down here, maybe in an altitude tent, I can potentially qualify them for oxygen, get insurance to pay for their oxygen, and see what the effects of oxygen are in somebody who's in a low oxygen environment, and see whether that's an adequate therapy.
Okay. What is the connection between sleep apnea and nocturia?
That's a good question.
Yeah, so it's an interesting question, a little bit tricky. So sleep apnea can probably cause some nocturia, and there's some physiologic reasons for that in terms of it puts stress on the heart and may cause your heart to kind of release hormones that make you go to the bathroom a little bit more, or make more urine and need to go to the bathroom at night. That's understood and known. I don't have any good data on if you have sleep apnea, how much more urine you're making or anything like that, but that's a plausible physiologic reason why you could have to go to the bathroom more at night. Another reason is that the sleep apnea could be waking you up and making you have to go to when you wake up from a sleep apnea event, you'll have a startle, wake up, and then you're awake, and then you say, well, I have to go to the bathroom, and so then you go to the bathroom. And there was actually a study where they had patients who were having polysomnograms who woke up and hit the button, told the technician, I have to get unhooked and go to the bathroom. And they said, well, why did you wake up? And they said, well, I had to go to the bathroom. But they could actually look and see the reason they woke up is because they had a sleep apnea event. And then once they were awake, they said, well, I have to go to the bathroom. If they hadn't had the sleep apnea, they probably would have slept longer and maybe would have not gotten up 4 times that night, might have gotten up 2 times a night. So that's the relationship. I do have patients that say once we get them treated, they get up to go to the bathroom less often. And presumably, I think they're just sleeping better, whether it's they're making less urine at night, or I think more likely it's just that they're sleeping more soundly, more deeply, and they just don't get up and go to the bathroom as often because they're asleep.
Is it true that CPAP can increase issues of tooth decay?
If it causes dry mouth, that's potential. It's not an area of quite of my expertise, but I've not seen any of that in any conference I've gone to talking about that. But if it's drying out your mouth, it could. The humidifiers on CPAP machines are really a lot better. That's one of the big evolutions, I'd say, in them, in terms of they're mostly used for humidification is primarily a patient comfort thing, but they're pretty darn good. You can turn those things so they're a desert or they're a rainforest, is kind of as much humidity as you want. I think if you keep the humidity up, wouldn't think there's a reason why you could promote tooth decay.
Okay. Are there any masks that incorporate chin strap or other devices for closing the mouth during the night?
Yeah, you bet. There's chin straps that are available. Those are pretty routine. They can be when anybody who's got CPAP and has a mask can go to their provider and get a chin strap. It's usually like a neoprene sling that kind of comes down under the chin and just applies some pressure. Helps keep the mouth closed. There's a little more common for nasal only masks where the mouth's more open, likely to open, but I have patients that are on full face masks and their mouth opens when they're even with a full face mask, and that can actually make the sleep apnea worse. It can make the mask leak, and also it can make the sleep apnea itself work, because when your jaw falls open, it doesn't fall straight down. It actually hinges back and actually tends to close the airway a little bit more. So it can mean that your CPAP that works when your mouth is closed doesn't work as well when your mouth is open, even if the mask is covering and putting air in there. So sometimes patients will have a chin strap to help even if they have a full face mask. So that's very easy to get. And again, you can get that any place you're getting your CPAP supplies. That's an included addition to your CPAP mask.
And one thing I was going to say about that is if you're mouth breathing, sometimes it means you're not breathing through your nose well. So I see a lot of patients that come in and they're trying mouth tape or something, and they have horrible nasal obstruction. And so to me, it's like, well, if you can't breathe through your nose, you're going to mouth breathe. And so I think it's important to eval your nasal patency before you start trying to close your mouth, because you may need your mouth open.
Exactly.
So.
I'll tell patients your natural condition is we were designed to breathe through our nose even at night. And if we're not, then that's something that can potentially be addressed and fixed, so you won't have your mouth open and need a chin strap.
So can you still get either one of the devices if you are a mouth breather?
Sure.
Yep, it can work with, well, if you're a mouth breather, a nasal mask probably isn't going to work unless you use a chin strap, or some patients tape their mouth when they wear it as well. But again, as Angela said, that's a reason to look at, why are you a mouth breather? Maybe that's the problem to fix, and then you won't be a mouth breather, and you won't have this
Some
problem.
people aren't tolerating CPAP because they don't breathe through their nose, and then you improve their nasal patency and they tolerate CPAP. So I think that's something that's fairly easy to fix that might allow them to tolerate the CPAP.
Okay. This person had a ResMed for several years. Do they need to get it serviced or adjusted at some point?
Usually not. There's your supplier, when you get it, if you're going through a DME provider, they'll usually provide you filters and hose replacements every 6 to 12 months or so. Besides that, those devices usually work pretty darn well. I have patients that have had them, not had any work done on them for usually about 10, 12 years or so is a typical lifespan, and they usually don't need any adjustment. Some of them auto-adjust for altitude, so if you came from a lower altitude, they'll automatically adjust, some don't. The modern ones mostly, I think, adjust to altitude. So there's really, just besides getting the supplies, the filters and all that go with it, really not a reason to have it checked out, unless you're having a problem with it. I have some patients that will go and have it pressure checked because they sense something's wrong with it. But other than that, unless it's making a noise, as long as it turns on and off, it's usually not a problem.
Okay. How do you know an oral device is working if you're not using a CPAP? Do you need to do another sleep study?
Yeah. So basically, I think any of these modalities, you get a sleep study with it, right? So, I mean, if you get the Inspire, you get a sleep study afterward to prove that you're at the right settings. If you get your nose fixed and you have mild sleep apnea, I usually will recommend a new sleep study after that to prove that we really, truly fixed their sleep apnea. And same with the mandibular advancement device. I think some of those devices, especially the ones that you can kind of just get over the counter, sometimes maybe don't have enough protrusion to really improve things. And so, if you're going to use it, you want to make sure it's working. So sleep study makes sense.
Yeah, and as you said, for any of these studies, for any of these other options besides CPAP, you really, in order to know if it works, you're going to need a sleep study. And that's, I think, one of the advantages of CPAP that I hadn't really covered is that when patients are looking at options, CPAP is probably the fastest option. I could see a patient, and assuming they're in stock at their DME provider, they can be on treatment within 48 hours or certainly a week or so, and we can know immediately if it works. I mean, they'll let you get a download on your phone, and you can wake up after the first night you've used it, and it'll tell you if it's working or not. And when I see you back in the office, I'll have all your data and know whether it's working or not. Any of these other options, they're going to take a couple months to get going, besides the positional therapy, weight loss, mandibular advancement device, or Inspire or surgery. It's going to be 3 months before you've gotten the device or the treatment and effective, and then you've got a test for it. So CPAP is certainly the fastest options for patients that really want to get things done. And you could have an oral appliance or an Inspire, it works well, and then how do you know if it's working 3 years from then, or you've gained some weight, or just 3 years later, or 5 years later? With CPAP, every time I see the patient, every year I see them back, I'm looking at the download, and I know whether or not they're using it and whether or not it's effective. So that's another kind of advantage, another reason that CPAP, I think, is kind of the preferred treatment, is that you always know whether it's working.
This person was diagnosed with REM sleep disorder and mild central sleep apnea. How would CPAP help?
It might help the central sleep apnea. As I said, my gist is that it's about 50% of patients will be helped. I wouldn't necessarily promise that would help the REM sleep disorder. That's really a separate sleep disorder. It might help with more sound sleep, but I wouldn't promise that that's going to help the REM sleep disorder. That really requires its own kind of different treatment pathway.
We want to remind our audience that we're going to get through just as many of these as we can. We're going to go over about 5-ish minutes, and we'll just keep on plugging here to get to quite as many as we can. Will folks who are overweight but not obese be able to get the weight loss drug for reducing AHIs?
That's a hard question.
That's not been determined yet. This study looked at patients who were BMI of over 30. So that's my guess is what the drug is going for in terms of the indication. So that's probably less likely, but I'm not in charge of that. So I wouldn't hazard a guess right now.
Okay. To clarify, the battery lasts about 11 years.
Yep, 11 years. Hopefully the new generations will last forever, but we don't have those yet.
Okay. Is there an age over which you do not recommend Inspire?
I mean, it's not necessarily the age. I think it's the health of the patient. So, I mean, there could be a 35-year-old that's not a very good surgical candidate, and I've done Inspire on an 80-year-old. And, you know, in some of those patients, they've got cardiac issues that are correlated to the sleep apnea and really need it treated. In those cases, we definitely want to work closely, like with your cardiologist and your primary doctor, to make sure that you're a good surgical candidate. But there's not necessarily an age cutoff for Inspire, no.
What dentist in the area can build oral appliance? They referred to a slide. They have visited several, they can't find one.
I usually refer people to Dr. Edwards. He's with this place called TMJ and Sleep Solutions. He's the one I know the best. I think there's a couple more, but that's probably the one we refer to the most.
Yeah, there's several dentists that exclusively do this, and some of those will take medical insurance as well. Not so many. That can be a challenge, is getting ones that will actually take medical insurance. Your dental benefits don't work. You really need somebody who accepts medical. Your medical benefits, they're enrolled in the medical plans, and they can bill your insurance for that. But there's lots of dentists that will do these devices. So a lot of patients, I'll just ask them, start with your dentist, ask them if they do them, if they have a dentist they prefer, and then I can kind of break out my list of a couple of dentists that I can recommend.
Is there a problem with eating, swallowing when the Inspire isn't on? Seems like it would be uncomfortable.
So that's a good question. I mean, if the Inspire is not on, which it should not be when you're awake, you're not going to have any issues with that. Now, granted, if you woke up and got like a urgent phone call in the middle of the night and you forget to pause it, yeah, you're going to have like little twitches of your tongue every time you breathe in, and it's going to mess up your speech. But you're going to notice that pretty quickly and pause the device. So if it's not on, it shouldn't affect that.
Because there's nothing actually in your tongue that's affecting it. It's wrapped around the nerve that goes to the tongue, and if it's off, there should be no effect.
Yeah, the surgery,
tethering the tongue.
we're not inside, we're external, which is kind of weird, so it's all external to the tongue base, even though it's moving the tongue base, if that makes sense.
How many Inspire devices have you done?
Maybe 60-ish, maybe a little more.
How does age affect sleep apnea?
So sleep apnea tends to get worse as we age. The risk factors for sleep apnea are age, male sex, and weight. So as we age, sleep apnea tends to get worse. So if I see a patient that has little or no sleep apnea, we do an evaluation, they're snoring, I tell them, okay, you don't have sleep apnea now, we should kind of rethink about this in 5 years, 10 years, something like that. It doesn't tend to get worse fast. The population studies have suggested that the AHI goes up by less than 1 event per hour on a population basis. But again, you also have to ask if you've gained weight. If you've aged 5 years and gained 25 pounds, that compounds the increased risk.
Okay. Does CPAP make you gain weight?
Now, the hope had been that would help you lose weight, because we know that sleep deprivation tends to cause people to overeat and have obesity, and also be less likely to exercise if you're tired and fatigued. So the hope had actually been that, and the expectation had been that if we put people on CPAP, or if we treat their sleep apnea for any reason, that they would actually lose weight because they'd have sleep better, they would tend to do less kind of hunger, less eating, and they would also be more active and exercise more. Unfortunately, studies have not borne that out, so we have to call it just a wash. Just it treats the sleep apnea, doesn't affect your weight.